I am a pharmacist, I'm a menopause educator, and I am a researcher. So I've been in the field of pharmacy for over 25 years in various areas, ranging from community pharmacy, managed care, research, regulatory compliance, and I am the founder of Menopause in Color, which is an organization that is for women of color who are going through perimenopause and menopause and want to build a community, want to learn more. And I'm also the owner of Integrated Pharmacy Outcomes and Consulting, which is my pharmacy hat as well. So I am so happy to be here and happy to talk to everyone today.
I'm Dr. Melita Williams. I am a Xavier graduate of class of 1995 with Demetrius Sloan. I am board certified in family medicine and also have additional training in board certified according to the American Board of Integrative and Holistic Medicine. And I work in Plano, Texas. I'm in private practice. I'm the owner of Healing Hands Holistic Health. I have been, of course, practicing medicine about 25 plus years now, formerly a Navy doctor, worked for a major hospital system, and have gone back out on my own in private practice, trying to educate patients about alternative measures that they can take to help with their health, and also helping in a holistic way, including body, mind, and spirit. I'm glad to be here.
Hi, good evening, everyone. I'm Dr. Larissa Ferdinand. I'm a board certified OBGYN and an integrative health and menopause healthcare specialist. I own a medical wellness practice here in Orlando, Florida, Thrive Beyond Wellness. I consider myself, just as many of the doctors on the panel, a unicorn, because we have all, based on the panel, have deviated from traditional routes because we realize that the need is so much greater than in traditional medicine. And so my lens tends to be through personalized medicine with proactive aging and longevity. I also have the hat of really getting into more innovations and using wearables and how to utilize wearables in this particular area. So I am very excited about dynamic conversation tonight. And hopefully, if anything, the goal is that you will continue the conversation beyond this thought leadership. So thanks for having me.
Awesome. Well, thanks everybody. All panelists. I'm sorry, I am from the class of '02. It's rude of me. And let's get into some questions. So, like I said, do we want to jump into some of the community questions, or do we want to get right into some of the panel discussions? If anybody, well, how about this? If anybody has questions to start with and they want to put those in the chat, please put those there. We'll start with questions, and as the questions come into the chat, we'll address them as such. But so, ladies of the panel, first question is, what is menopause, and when should women start paying attention to perimenopause?
I guess I'll start. Perimenopause, it really is a transitional time when a woman goes from being consistently having menstrual cycles and the ability to have fertility and have children to the point where she transitions, changes in the hormones are occurring where that cycle is not as regular, and until it ultimately stops because of quote unquote ovarian failure, because of the lack or loss of hormonal production, more specifically from the ovaries. So that is a definition of menopause. It used to be noted as a single day, 12 months after the cessation of your menstrual cycles, and then you enter into the postmenopausal stage. But we know that it's a spectrum that goes throughout a period of time from anywhere from 5 to 10 years, with symptoms lasting in the postmenopausal stage for several years after that, sometimes even up to 15 years, with specific genetic groups, or African Americans, and Latinos probably have even longer periods of symptoms in the postmenopausal time. So.
Just as an addition, just to put some average framework, what you may hear out there is not only the absence of a cycle for 12 months of a uterus that's intact. And so many women that come across may end up with a hysterectomy with a common reason, pelvic pain or fibroids. So how do we identify those women? So let's put some age brackets to it. So the average age of menopause is around 51 years of age, but as far as the spectrum of symptoms, it can start well into your mid-30s to late 30s to early 40s. Majority of women will start complaining of symptoms that we'll go through in the spectrum of around 45 to 55 years of age. There's 1% of the population that could be premenopausal. So we're talking about less than 40 years of age, meaning like an absence of that cycle for 12 months, or actually definitive not having that constellation of spectrum of perimenopausal symptoms before the cycle has stopped. But actually, that could be due to surgical reasons because the ovaries have been removed at an early age or at a time of hysterectomy. I love using the word transition. I love using the term menopausing as well because that constellation of symptoms can happen. And the conversation should start as early as 30 something, as far as I'm concerned. My goal and my mission is that this will become a more transgenerational conversation where the newer generations are wanting to know how to prepare for it because our moms or our elders really didn't talk about it as much. And so this proactive conversation to me will always be on time because it has to do with hormonal fluctuations, and especially for Black women, that can occur well before your period actually stops. So I wanted to add some context to that as well. You're on mute.
Unmute.
And we've been doing this since before 2020. I would think I would have that by now. So to piggyback on what Dr. Ferdinand and what Dr. Williams said, as far as the average age of menopause, and I think we're going to talk about this later as well, but I would be interested in seeing knowing if you are seeing it early in Black women. Now, I'm seeing studies that are showing that it is about 8 months to a year, sometimes even as long as 2 years earlier. So a lot of times we're starting to see that average age of about 49 years of age, which actually, I'm actually in menopause and I was around 48 years of age when I reached menopause. So I think that when I was younger, I really thought that menopause was a lot older and I would see it in a lot older women. But when you really look at those stats, especially even for some Black women, we are starting to see it a lot earlier as well in some of the studies too.
All right, so we had great answers. We had a question in the chat that said if she was under 40, a young woman that was under 40 and hadn't had cycles in 4 years, and it was recommended that she take estrogen, and she wanted to know the thoughts on, premature ovarian failure and what does that mean and what's the treatment for that?
Well, I can start. So if that's the case, definitely you did have premature menopause. If you definitely had the absence of a cycle way before that time period of the average age. So we can go ahead and translate it within that particular definition. So I always like to start with this is not a one size fits all when we approach menopausal care, or let's just say any stage of menopause, whether we're in perimenopause, the time frame of menopause, or postmenopause. I think this is a good time to discuss what are some of the symptoms and the things that could be related to it. And one, is not one size fits all. Two, it affects your entire body. So from areas of your brain, your skin, your heart, your vagina, your urogenital system, your bones, your muscle. So understand, I like to make sure that the bigger conversation that I love about this panel is that it's multidisciplinary. We want to get more physicians involved with that. So translating to estrogen, and we'll have more dynamic conversation when we tackle a little bit more about hormone therapy, you would be a great candidate for it if you do not have some of the contraindications, because we know as of now, starting a woman on potential estrogen therapy at a younger age, you're going to have across the board better benefits when it comes to a brain health, heart health, bone health, preventing osteoporosis and bone fracture at a later age, and overall well-being. Because this is a month of mental health awareness, and many of the things that have been dismissed is, oh, increase in anxiety, increase in depression. I think I'm going back crazy. I'm breaking up with my body type situation, and then many of those things could be related to just the loss of estrogen itself, because we have particular cells that want those particular hormone reactions to those receptors on our cells. And so therefore we'll have greater benefits across the board. So I don't know your medical background and some of the specifics that we hopefully will unload a little bit later, but I want you to make an informed decision. That's so important. Do not make a decision out of fear. Do not make a decision that is based on, well, my mama told me not to do it. Understand that your body makes it a personalized decision, makes it an informed decision, and most importantly, it makes it an active decision. So those things need to be in a way where you're approaching estrogen therapy not as, oh, should I take it or not, but I know why I'm taking it.
Yes. And just to add to that, if someone has premature menopause and they're lacking the production of those hormones, just as she said, there are receptors for estrogen throughout the body. And specifically, when you think about all of the symptoms of menopause, a lot of them start in the brain. So cognitive decline, even hot flashes, brain fog, memory issues, trying to find the right words to say, all of that is related to cognitive function. And so those estrogen receptors in the brain, when there's lack of estrogen, there can be changes in the actual anatomy, or how your brain actually looks when they do like functional MRIs and things of that nature. And so everyone's afraid of dementia and Alzheimer's and all these things. And we're hearing about that and knowing about that even from our parents, grandparents, and all those things. So there is even an increased percentage of risk of having dementia with even just the removal of one ovary, just from a surgery, like having an oophorectomy for whatever reason. So to have loss of estrogen from both ovaries, like complete ovarian failure before the age of 40, you have to think that is an increased risk as well. So just as Dr. Ferdinand was saying, we're talking about quality of life. Your hormones are there for a reason. You were born with them for a reason. They helped you develop. They helped you become who you are and how you look, how you respond, and everything about you. And the loss of those hormones, even though there are some changes that you'll go through, it doesn't completely take away who you are. However, without them, there are definitely going to be more drastic changes in who you are as far as how you relate to other people, how you're functioning cognitively, and your ability to show up in life.
I think that it's important as well that we remember that estrogen is cardioprotective, right? So
Yes.
many times when we're talking about replacing hormones, we're just thinking about that we're just talking about symptoms, but it's your overall health as well.
Mm-hmm.
So removing that estrogen, supplementing with that estrogen is also cardioprotective, whether it is protecting from your heart or protecting from things like diabetes or protecting from things like obesity. But we forget about that portion as well, and that's not talked about enough. I see a lot of women who will go and either have premature ovarian insufficiency or they will have a hysterectomy, and their healthcare providers, and not Xavier providers, of course, are not telling them that they either should have an option for taking that. And don't get me wrong, like Dr. Ferdinand said, everyone cannot take it, but they don't even know, or they don't even have the option to learn more about it as well. So I think it's very important for us to remember it's not just about replacing your hormones. Hormone therapy is also about being cardioprotective and about your whole system, about your whole body as well.
Mm-hmm.
Awesome answer. So we'll transition to the next question, which is really a hot topic I deal with every day is, and how do you get your hormones tested? Like when women want to get their hormones tested, what's the advice on that from an age perspective? And do you routinely do that? Can you guys speak on that?
You wanna start?
I'll start. It's easy to test your hormones. You can start with blood testing. So most individuals can get their blood tested for different levels. And there's typically an ideal window of time to check your hormones so that you can see the ratio between, for instance, your estrogen and progesterone levels. And that is typically days 18 through 21 of your menstrual cycle. And if you're having irregular periods, sometimes, we're dealing with a moving target here when you're talking about perimenopause. So sometimes, it can be a little challenging to actually do that. However, they can be done through the blood. There's also specialty labs that also will test through urine as well as saliva. So there are various ways that it can be tested, and some of those kits can actually be sent home with you, or you can order them online and have a provider that can actually help interpret those results for you. But definitely it's an easy test, but sometimes you actually have to advocate for getting your tests, your hormone levels checked, because some conventional doctors or those that may not be as apt to quickly check your hormones if they're, dismissing certain symptoms, they may not even consider the hormones. They might just say, oh, you're having mental health issues. Let's just put you on an antidepressant. Let's just do this. But you have to advocate for yourself as well to make sure that you're looking at your health holistically and not just treating a symptom, but finding out what the root cause is.
Go ahead.
No. I was. If you got something to add, then go right ahead.
Dr. Ferdinand, you want to? I want you to go first because you have your clinic, but I do have something to add as well.
Oh, okay. No, one of the things I was going to say, because there's so much out there.
Mm.
And I tend to be a practical pearl type person too. Just like many things in medicine, you're going to have some docs that do this way, and other docs say, no, we don't do it that way. And so I agree with everything that Dr. Melita had mentioned. There's different ways that you'll test your hormones and why. I will say definitely if you're menstruating, it's best to do it time sensitive, because going back to the receptor effect, you can have certain levels, especially around perimenopause, where this is a major time of fluctuation of your hormones, especially estrogen, where that particular value may be asymptomatic for one person and your spectrum of symptoms might be different from others. So with that being said, I think the bottom line, no matter what, when it comes to testing, don't let a test or a non-test overlook what you're experiencing.
Correct.
Because for years before a lot of these companies are starting to make multi-million-dollar bucks of different testing, and I do different testing because it's available and knowledge is power. But still, a woman, over 70% of women were being dismissed just because of symptoms that we knew we could treat honorably. So I think the main thing that I want to get from that is, regardless of the testing and being educated of the testing, being able to be to track your symptoms, discuss your symptoms, and make sure you understand your options for treatment, because there's certain lab testing that can still say normal, but is not optimal, and you're still feeling like you're crazy. So just make sure that you're taking that extra step in understanding it's there, it's knowledge. It can be used to tailor your treatment or tailor a more comprehensive approach for the strategy of your health plan. But understand that even having certain clinical symptoms can indicate something that your lab testing isn't picking up.
Yep. And that's why I was gonna kind of go with this, is that if you have one of your healthcare professional and you're having signs and symptoms, and if they listen to you and they check off these certain signs and symptoms and they know your medical history, a lot of times they'll be able to say, you know what, you are perimenopausal or you're late perimenopausal, et cetera. But I get a lot of consumers or patients that can't afford testing, right?
Mhm.
And if they have a healthcare professional that can listen to them and they know their symptoms, then the testing may not be required for them. So I think what both you said is very important. Make sure that you have a healthcare professional that understands and that's listening to you. I'm gonna be honest, my healthcare professional at first did not listen to when I was saying that I had heart palpitations. I went and got a ECG done, I believe, and it came back normal, but no one ever talked about what it could have been until I started researching myself and saw chart checking off the list like, wait a minute, this is perimenopause. And then I ended up doing testing because I have an ablation. So I did not have a cycle to tell me what was going on. So I think even looking at that medical history, if you don't have a cycle because of a medical procedure, then you probably will need to get testing. But if you have all of these different things that you can check off and you have a healthcare provider that's listening to you and taking what you have to say and really listening and understanding what you're saying, then sometimes you cannot, you can get away without it.
And
All right, so it's a ton of questions. So I'm gonna try to get as many answered as possible. So I'm gonna target questions to each of you specifically, so that we can get through as many questions as possible. Because we can talk about some of this stuff all day long. We got a wealth of knowledge, but I'm gonna try to point some of these questions. So with that said, we'll go back to forth. Dr. Moss, for you, there's a question that was asking about is there a link for between menopause and the decreasing of hormones to lack of concentration or lack of focus? Can you speak on if there's any link to that?
Yeah, so Dr. Williams kind of touched on this earlier when it comes to the brain and your hormones. Of course, when the mental aspects of menopause and perimenopause, and even the most symptomatic time is actually perimenopause. So you forgetting those words that when you're giving a presentation at work, I hear a lot of women coming in when they are in the C-suite and they can't remember a word that they said, or they just like now that I'm about to do, or they can't remember certain things that they have to do. So those mental aspects, so even with your mental health, with your cognitive ability, all those things can be affected by your hormones. So there can be a link between both of those as well. And I will give the other doctors, if there's anything you want to chime in, feel free to chime in on that as well. But Dr. Williams, I believe you did touch on it.
All right, I'm gonna keep it moving. Everybody gonna have time to talk. So, Dr. Ferdinand. So, and just to piggyback on that, are any of those symptoms, such as lack of concentration or focus, like protected under FMLA, or can you get special considerations at work because of it? Can you speak on that?
Well, this is a good time to talk about the A's, which is one, advocacy, outside of awareness, and then those who can be your allies. So this is where advocacy is. And there's many movements in this space, but honestly, being around different leaders in this particular corporate space, this is a challenging conversation because corporate or just businesses are still trying to wrap their brain around it. So for some that may be familiar, there was a documentary that dropped in the fall called The M Factor. What people don't know in the back end, that's actually been offered to corporations to educate internally. It's interesting, even being on that backdrop and wanting to be a part of the conversation and be allies and advocates, it still hasn't been true reform on a human resource level. So I think some of those same ticks or boxes need to be checked as far as incapacitation, some form of disability potentially, if we're talking about that extended amount of time away. So this is where many of the things are trying to get pushed, or or whether it's legislation, whether it's forming bigger bonds within the House, the Senate, or just pushing these things through smaller committees, because it's like many other things. Unless it changes on a government behalf, a lot of private equity or private corporations do not follow suit. But I will say that there is more conversations. There's more awareness, there are more advocates, and therefore allies that are there speaking on our behalf when we're not there. So we're moving the needle, but just don't think that it's moving a lot. There's a saying in medicine that sometimes as we come out with one thing, technically it takes about 30 years almost for it to be completely adopted with more widespread. So I would say if you have pull or have any particular voice in your company, this is a time to make it known because every voice can count and it makes a difference for our daughters behind us. Like I said, this is more transgenerational conversation. And so we want to make sure that that links throughout, even in our corporate or our business settings.
And don't hesitate to reach out to one of us as well. I know they have M Factor, but I do have corporations that reach out for education as well. So don't, you have a Xavier Network as well. They can get on the Zoom and talk to some of your professionals as well.
Absolutely. Thanks for that, Dr.
Yeah, and unfortunately, I'll piggyback on that. Unfortunately, women's healthcare is at the end of the totem pole as far as priority systems for the healthcare system as a whole. If you look at reimbursement for gynecologic surgeries or any type of OBGYN care, it is at the bottom of the barrel for everything, which shows it's a reflection of the misogynistic society we live in. So, you can get your hip replaced and get reimbursed 5, 10 times more than a hysterectomy or anything else, and that's a fact. And unfortunately, is people don't really understand that, but it's really bad. So the fight for equity in healthcare for women is a big need. But to that point, let's move on to Dr. Williams. This is a question that asks, what are some of the common causes of postmenopausal bleeding?
Common causes of postmenopausal bleeding. Well, the first one would be unopposed estrogen. If someone is actually taking estrogen or if they're overweight or obese, there is an increased risk of increased estrogen production in the body by what we call aromatization. So being overweight is one of those risk factors. And because of the effects of that hormone on the endometrial lining or the inside lining of the uterus. This is the lining that typically sheds when you have your menstrual period. If it overgrows or hypertrophies, it can start causing spotting or abnormal bleeding. Of course, other hormones are imbalanced during this time as well. So if progesterone is lacking and it's what we call estrogen dominance, then you're not going to have a stable lining and it can cause growth. One of the other things that causes bleeding is if you do have a fibroid, and as those hormones are shifting and changing and progesterone levels are dropping, it's one of the first hormones that starts declining, then people have heavier bleeding and things of that nature as well. But fibroids typically will kind of involute a little bit or decrease once someone goes through menopause, but it doesn't mean that they don't have issues or can't have any cramping or issues as a result of the fibroids being there. The other thing is if you're taking postmenopausal hormone replacement and it's not done appropriately or monitored, and if you're having issues with metabolizing your hormones appropriately, that might cause some issues. Infection, that can also cause issues. If there's polyps or overgrowth of some tissue that is being irritated, those are things that can cause some bleeding postmenopausally. And you would definitely want to present to your healthcare provider so that they can do endometrial biopsies or ultrasound just to see what's going on, because you need a tissue diagnosis. Bleeding after someone's gone through a full year of not having a menstrual cycle, the most common thing or thing we want to definitely rule out is endometrial cancer. So that definitely needs to be evaluated.
Great thoughts. Absolutely. The only I would add to that and just say, listen to your body, right? So your body gives you signs and symptoms when something is wrong. 99.9% of the time, postmenopausal bleeding is most likely going to be benign. but don't fall into that less than 1% chance that it's not. So don't ignore signs and symptoms that your body will give to you, and just put it off like it's just one of those things. So just listen to your body. There was a question about pelvic pain and fibroids. I will not get into that right now because I will go on my soapbox, and because that's my wheelhouse. So if we have time at the end, we will touch on that some, but we will keep this to menopausal discussion. We'll reset the room and just say, hey, this is a discussion, open forum on menopause. So if you have questions, concerns that you want us to discuss, please drop them in the chat. I'm looking at those and writing those down and addressing them, one by one. So please feel that you will be heard. If you have those, just drop them in the chat. Back to Dr. Moss. What are the best ways to manage hot flashes and night sweats?
Well, I would say according to the FDA, it is estrogen. I mean, it is using your hormone therapy, and I do agree with that. But there are other ways that if you aren't a candidate for it, or if you choose not to take it, you can, of course, which I think everyone should, of course, start with your lifestyle changes. So, what are you eating? What are you drinking? What's going on there? So, I actually, for myself, I like to keep a diary of what am I eating that day, and did it affect my hot flash or my night sweat that night? Is one of the biggest things, because there are some food triggers that can also affect that as well. So look and see what you're eating. Spicy foods, caffeine, sugary foods, those types of things can really affect it too. But besides that, of course, your hormone therapy, but there are things like your vitamins. What vitamins are you taking? Are you taking your magnesium? How do your magnesium levels look? Your vitamin D levels, your vitamin E levels, all of those lifestyle changes are very important when it comes to managing hot flashes too. And then also look and see what type of things how are you managing? For instance, if you get hot, I know Dr. Ferdinand talked about wearables that she is also very, I believe it was Dr. Ferdinand said that as well, that wearables is very important to her as well. So if you are going to a meeting at corporate and you have on a wool sweater, did you line that day? Do you have on something that you can take off if you're meeting and you get hot? So look at that. But I think the biggest thing is, besides your hormone therapy, of course, would be your lifestyle changes, and then also your vitamins and nutrients. Yes, you will have your herbal supplements out there like your maca root, your black cohosh. But I think if you decide to take those things as well, you need to, first of all, make sure you're talking to your healthcare professional, and then also making sure that it's from a reputable source if you choose to take that. I think those important. I wouldn't suggest that you just start to take an over-the-counter supplement, especially a supplement that has various things listed in it, unless you're talking to your healthcare professional and they're talking to you otherwise besides that.
Dr.
Anyone else
Ferdinand,
want to add? Yeah.
Dr. Ferdinand, any other non-hormonal options when there are contraindications to HRT that you want to add in?
Yes, and I love how you talked about Dr. Stephanie, because it does start with lifestyle. And I'm answering this question, but I'm also putting the wrap around sleep, because many of the times that we're having disruptions of sleep is because of vasomotor symptoms like your night sweats and your hot flushes, going back to lifestyle and quality of life. So let's just talk about alcohol a little bit.
Yes.
There you go.
Yes. Yes.
That needs to be covered in some kind of extent, because that occasional stress management tool that we're using sometimes at night is potentially affecting the severity and the frequency and the prolongation of having those vasomotor symptoms that can impact your sleep, that can impact your cognitive ability and your energy. So once again, from a functional, or lifestyle standpoint, before you're adding molecules and medications, then let's also look at it from that. An FDA approved medication called Veoza is out currently, that is a non-hormonal method for hot flushes, specifically for vasomotor symptoms, so hot flushes and night sweats. So that is an option. If we're looking for outside of that, in the innovation world, just kind of adding that, there are wearables that can be from your sleep number bed to a wrist wearable, which sometimes people don't like to wear jewelry, et cetera. So I do understand that. But they even have clothing lines now to make sure that you have more breathable wear when you go to bed, because that's when it can impact through the day. But I really try to focus on also, is it really disrupting your sleep? Because sleep is queen, sleep is sexy. I want people to honor their sleep. And that is a big one because for some reason, I'm sorry, Dr. Pierre, a man said one day, sleep when you're dead, and
Oh my God.
you don't sleep enough. So anyway, so I wanted to add that because that is a very important component when we're talking about non-hormonal. Some of the stuff that you're doing every day just happens to be part of that recipe or prescription that you need before you even add the medications or the molecules. So
And I'll
All
just
right.
add one other thing to that. I know we don't want to put a whole bunch of herbs and things, unless you know the side effects, because they do interact with our other medications. Unless you're having someone that's just supervising and giving you good guidance on that. The second thing is some people, it's approved to do certain antidepressant medications that are approved to help with hot flashes as well. Now they have, cooling comforters, they have, but essential oils is also something that I truly enjoy, or encouraging people to use as a alternative. Peppermint oil is very cooling, so you can actually put little dabs on your wrist, behind your ears, and your neck, and it will also help with cooling down too. So those are just a couple little things I just wanted to throw out there too.
One thing I will add that I tell my patients all the time is that you have to really understand what it is, and your hot flashes are due to the lack of control of your thermoregulatory centers. Right. So when you have this lack of estrogen, the controls that you have for subtle changes of the external environment, you lose those. And so, for instance, if there's a slight drop in temperature or an increase in temperature, your body doesn't respond like it once did to that. So one of the big problems where, women often have is that you'll have horrible night sweats. And why does it happen at night? Because you're trying to beat the hot flash. You're going to bed naked, or you're opening the window, or you have air conditioning on and you're trying to make it so that you're going to beat the hot flash, when in fact you're worsening that by trying to beat it, because your external environment is now dropping and your body internally is now saying, oh, okay, let's flame her up because she thinks it's cold outside. So one way that you can kind of counteract that is trying to keep it as neutral as possible in your external environment, as opposed to trying to make the extremes for hot and cold. So that's just one tidbit that I'll throw in there. But going back to Dr. Moss, would you or should women greater than 60 years old ask about hormone testing?
Well, I will say, according to Menopause Society, they prefer in their statement that you start prior to 60 years old, or if you have not been in menopause for at least 10 years. But there are there are some studies that are starting to come out that women over 60-year-olds can actually start hormone therapy. But like we've said before, one size does not fit all. Make sure you talk to a healthcare professional. But make sure you talk to your healthcare professional about your medical background. But typically, the Menopause Society says at least 10 years before 10 years not being in menopause. But there are some studies showing that women can actually, after 60 years of age, can start hormone therapy as well.
And so, and thank you for that, Dr. Moss. Dr. Williams, is there an
I'm
Indian?
sorry,
Go ahead.
Dr.
I'm sorry.
I'm
Go ahead.
sorry.
No, go
I want
ahead.
to make sure that we know with that hormone therapy that they know that there are several different options of what they can do too. You have
For
your
sure.
creams, your pills, your patches, your all different types of things. So, when we say hormone therapy, a lot of people think about pills, but there's various things that you can do too, and various ways that you can start. So, especially being at a certain age, you may want to talk about that too with your healthcare provider.
And
The reason is
there's
because of
various. I'm sorry. Go
yeah.
ahead.
The reason that there's an increased risk of certain things after 60 with starting is because of the cardiovascular risks. If you start before then, it may decrease your risk of cardiovascular complications. Starting later, it may increase it. And, I had a thought, and, this is just how my brain works. But when the HRT study came out 20 something years ago, all of those women would have been born before 1979 when they took lead out of gasoline. And so they were saying how, of course, we know that it's the synthetic progestins that was the culprit in all of that. But and estrogen in general was very helpful because estrogen helps prevent the breakdown of your bones. And so one of the thoughts that I had was, why are people getting palpitations? Why is there increased cardiovascular risk for a woman that's approaching that of males, by the time, 10 years after menopause? And of course, they assume it's because of the loss of estrogen. But my question was, is it because they could also be leaching lead into their bloodstream because their bones are breaking down, and some of those things that were bound in the bone may now be causing those cardiovascular risk factors as well? So of course, if they didn't test for heavy metals back then, you probably don't know. But it's just now I'm seeing a lot of patients that are coming in with cardiovascular issues. I'm doing heavy metal testing, and we're finding lead not only in cardiovascular patients, but also diabetics, from the childhood cessation therapy. So there are lots of other things that need to be looked at, but the hormonal presence is helping to quench or prevent some of the things that people may have been exposed to before. But there are also younger individuals, because of where they live, what they've been exposed to, they may also be having issues with these things, plastics and all of these other things that are hormone disruptors that may also be contributing to like infertility and all of premature menopause, all of these other issues from hormonal imbalances that also need to be addressed. But the reason I just wanted to bring that out about the cardiovascular risks with starting it later. But of course, if you're looking at it from a holistic perspective, you're going to find some of those other things that need to be addressed as well, and hopefully help them with their quality of life, because of course we're living longer now than we did before. So you're going to have to help individuals get through that with their quality of life.
And so, and everybody, like, let's always realize that medications do have side effects, right?
Yes.
So, and you have to be very cognizant about it. And I see HRT thrown around like candy a lot, and providers have a lack of explanation, to patients. So, as much as we do our research about everything else, I notice with patients, when there is a desired effect, the research kind of dwindles, i.e. with our, weight loss medications and a lot of other things that we take. So, but, realize that things have side effects to them, and they should be used appropriately. When the risk outweighs the benefit of it, it should be thought about again. But if there's a benefit, if you have significant quality of life issues because of hot flashes and are purely miserable, then we can start talking about HRT. But if things are functional, we need to talk about some of these things that are not hormonally regulated. But keeping it moving, Dr. Ferdinand. So there's one of the ladies in the audience that has never had a hot flash and is 53 years old. Is it possible to never have hot flashes?
Absolutely. Absolutely. There's a spectrum of menopausal symptoms that could be like literally over 30 related symptoms. And there are many women who do not end up with hot flushes, even though 70% of women can have those and experience that. So let me just answer that and go.
So I think that is just to pick up back off what she said, if we're still doing that, is that everyone is different. So it's important to remember, if someone says, well, and you'll see this a lot of times in corporate, well, it wasn't that bad for me, or it wasn't that bad for her. Everyone's different. You may have someone with one symptom. You may have someone that has 20 a different symptom every day. So it's important, like you said, it is a spectrum, and that we don't discount others if they are having symptoms, if they're having a hard time as well, because it is a range as well.
So there was a question about just going back to the memory loss. I think tips of how to counteract memory loss and also how to counteract significant mood changes in menopause. Dr. Williams, if you can speak on that.
Well, the first thing we always look at is lifestyle. If you're not moving, if you're not exercising, that is key because your brain needs oxygen and circulation as well. So some of the issues with cognitive decline can be related to vascular insufficiency, like people that have high blood pressure or have had strokes and those types of things. And so if your vascular health is being challenged, one of the best ways to improve your circulation to your brain is to exercise. It can also raise natural endorphins, which will elevate your mood. So it can also help with some of the, the mood changes that some patients will have as well. So the first thing I would say is get moving because that's important for life, in general.
So someone asked about just again going back to the fibroid discussion with UFE. I could talk about this all day long. If we have time, I will talk about it. But on the nutshell, I am totally against uterine fibroid embolization for a multitude of different reasons. Is it an option for fibroids? It absolutely is. But I will discuss, at a later time why I am not a proponent of UFE and will tell nobody in my family or patients to utilize the procedure. But moving on. Um, someone just going back to the patients greater than 60, it's someone that's 65 years old, still having horrible hot flashes. Are they too old for hormone replacement therapy? So either Dr. Moss or Dr. Ferdinand, can you address that?
Earlier we discussed it that typically it says if it's 6 years of age or if you have not been in menopause for at least 10 years, but typically you are starting to see that women who are 65 years of age are starting to be put on some type of hormone therapy. So whether it is a patch or some other type of modality, that they are being able to use that as well. Dr. Ferdinand?
Yes, totally agree. And especially based on that's what we know when we look at risk and benefits. So a decision should be based on a scale. What is my benefit versus risk? So that should be throughout everything. And then making sure that your clinician does a very detailed history from if you are someone who's on multiple medications. A lot of times I'm removing something. You've been scrolling so much, you're on 5 different supplements, and that may cause, your hot flushes all of a sudden, especially on very historical timeline wise. Like, have that been ever since you went through menopause, or did they just start? And I think this is a good opportunity to talk about metabolic health because at the end of the day, one of the most important hormone replacement or evaluations of hormones has to do with how you regulate your blood sugar, right? How insulin is a major factor. So outside of the weight loss drug, really the issue was as far as how is insulin utilized to make sure your body is taking blood sugar, using it for energy versus storing it as fat. Thyroid, major factor in women. Most women have thyroid issues. So, and we're having a conversation about menopause. Menopause is metabolic health. Menopause is overall proactive aging. And right now we live in a traditional healthcare system that's very reactionary. So if it's something that you want to take from it when we're talking about brain health, cardiovascular health, skin health, vaginal and sexual well-being, and many of these other constellations, is really looking at the whole person. Because if we start navigating once again, and I think Dr. Pierre mentioned that or someone else about just symptoms, then you're disregarding a whole system. you know? So if speaking specifically of the person who had mentioned their symptoms, just make sure that someone's doing a comprehensive. If they're only looking from one lens at that age, they're missing the boat, in my opinion, because that there's cardiovascular, there's of course cognitive health. There's so many things to address to make sure we're decreasing accelerating aging, to make sure we're reducing the chronic stress that even happen among Black women, just dealing with the vast inequities over our lifetime. And a lot of things that are being discussed in more advanced medicine communities has to do with just not only metabolic health, but how we're aging, how our body is not able to take care of the junk and throw it away. Why are we increasing our risk of cancer at an early age? What part of our diet is impacting on our cells where we can't even defeat chronic illnesses, where we're getting high blood pressure at earlier ages or diabetes, you know? So I think our focus sometimes often gets on that drug and what I need to take, which is great. I mean, like, I want to lose my 10 pounds for my birthday. Okay, get it, fine. At the end of the day, if we're really changing conversation within our community, then we really are talking about comprehensive metabolic health. If you're talking about hormone replacement, then someone should be talking about at this point, what are your numbers? What is your fasting insulin score? What is your hemoglobin A1C? What is your recent thyroid testing? What if you've gained weight, then what is a simple thing that, you know, I do, what is your waistline? You know, if you're over 35 inches, you're already increasing your a cardiovascular or stroke event. And a lot of that could be due to just having increased stress receptors in the abdominal area, which some people call menobelly. But there's issues or problems that happen in menopause that has to do with insulin and blood sugar regulation, just with the decrease of estrogen. So, navigating the conversation, especially in our community, really does have to focus on many of the things that, you know, our wonderful panelists have mentioned. And if we're talking about hormone replacement, understand there are other hormones that are impacted in the menopause age arena, and that's a third of your life, right? So a third of your life will be in this period, and it's best to go ahead and address it where you're reducing other effects just as well, and not just looking at it just from estrogen, or not just looking at it. They can definitely be a benefit, but also make sure that you're understanding your numbers, how they impact you, and how you can strategize better for your particular outcomes and improving your quality of life.
All right, so we have time for just a couple more questions. We're getting towards the end. So Dr. Williams, uh, can you speak on any illnesses that can be mistaken for menopause?
Well, when you're talking about hormonal imbalances, which is really the transition is to cessation of menstrual cycles or bleeding. Those that still have a uterus, I'll just borrow that from Dr. Larissa. The PCOS comes to mind. Some people will have periods of time where they won't have menstrual cycles, and due to multiple issues with insulin resistance, lack of progesterone, low vitamin D, problems with how their ovaries are responding to the pituitary. They will go for periods of time without menstrual cycles. And so that is one thing, one reason why hormones need to be checked, just to kind of see what's going on with the overall picture of this person. Are they not having periods because they have this hormonal imbalance? Thyroid, as Dr. Ferdinand was also saying, if it's overactive or underactive, can also cause some disruptions in your menstrual cycle as well. And the hypothalamic pituitary adrenal axis of this whole little system in us is very complex in females. And I think that's why God shut the lights off on guys when he made us, because we're so complex and he didn't want them to figure that out. But we're so complex that there's so many different pieces, that could also affect something else. So when someone doesn't have a uterus, or if they've had an ablation and they don't have routine menstrual cycles or bleeding to show the irregularities or what's going on, some people may present with symptoms of anxiety or depression, and they are treated as a mental health patient, and their mental health is challenged. However, if your thyroid's low, or if your vitamin D is low, or if your hormones are off, all of those things can contribute to some of the mental health presentations that someone comes in with, which is why you have to look at the person in a broader spectrum or way, instead of just blaming it on picking one thing and saying that's it, and you'll miss that. Even individuals that have anxiety or bipolar disorder or schizophrenia, you can even delve deeper and to find toxins such as, mold toxicity and things that are actually negatively impacting the neurons in the brain that's presenting with some issues, or causing their symptoms, and they're diagnosed with this, and it's something totally different, and they're tired, they have low energy, and other things can be disrupted, and you may think it's hormones, but there's so much more. So it has to be. There's a broad spectrum of things that need to be evaluated, because we are complex, and because there's so many different things that can impact your health with regards to your hormones.
Awesome. So we got time for one last question, which was only one last question in the chat, and I think we've covered a ton of the proposed questions as well. So, Dr. Moss, can you speak on if the correlation between menopause and osteoarthritis?
Okay. Well, a loss of estrogen can really lead to like a cartilage breakdown, and especially some of your joint deterioration that women may see. So those hormonal shifts that you see really can affect that as well. So a lot of times, especially if you already were prone to it, a lot of times you will see it worsen. But with those hormonal shifts and changes, a lot of times women will see that. So that is either a hormone therapy, sometimes, of course, can help with that. But then also things like are you still moving? A lot of people, if their joints hurt, they will stop moving. They will stop exercising, not realizing you're losing that fluid to help you keep moving and help keep those joints going. So I think that's very important that you continue to move and exercise. And also, what are you looking at in your diet? Like your vitamin D. If you can't get enough calcium in your diet, then taking that calcium with a vitamin D and vitamin K would be helpful, so that you can get that into your bones and your joints as well. So those are all things that are helpful with that. But I think the biggest thing is making sure that that those estrogen levels can affect your joints and your muscles and bones, of course.
Awesome.
And I want to add, you did mention vitamin K, but I specifically want to say vitamin K2. There's
Yes.
two different forms. A K1 that has more of a effects on your coagulation. So when they tell you, if you're on warfarin or all these other blood thinners, you don't eat greens. Well, they have new ones now, so it doesn't matter. But that's why. It's because it blocks that vitamin K1. But vitamin K2 specifically helps with diverting that calcium into the bones. But another thing it does is also helps with reversing calcifications in blood vessels. And so I won't get into that, but so that is whenever someone's taking vitamin D3 specifically in higher doses, it should always be coupled with K2 at a minimum. Also, vitamin A can sometimes be helpful. Vitamin A, D, E, and K are all fat soluble. So sometimes it's better to have them all together. But definitely, if you're taking D3, take K2 with it.
Yeah, and typically you can find those together. So thank you for adding that on. You can find that vitamin D3 and K2 a lot of times together as well.
Mm-hmm.
So, Dr. Ferdinand, just one last piece of advice that you would want in 2 to 3 sentences that each woman can take away from this conversation.
Don't normalize your symptoms. Do something about them. And my third sentence, you can reach out to us in the Alumni Association if you have any additional concerns or questions.
Dr. Moss?
I think the biggest thing is to just make sure that you're able to advocate for yourself. So even coming to this session is very important because you're learning, you're hearing what we're talking about. So if your, healthcare professional tells you otherwise, you can say, well, you know what, I learned this. Can we talk more about that? So being able to advocate for yourself and building a community where you're not afraid to talk about perimenopause and menopause, because our parents didn't talk about it because no one talked to them about it. So this is one of the first steps, is making sure that we're talking about it and the next generation will be comfortable with talking about it as well.
Dr. Williams.
Um, I would just say, like reiterating what they're saying about advocating for yourself and talking to your doctor about what you have learned and taking it to them is kind of what mainstream media has done to a lot of people. They went straight to commercials and telling, ask your doctor about this medicine. Like, what? I don't even know what that is, right? So take the information to them because it will also help educate them about some things that they actually need to know. You're not alone in this. I am in this process with you. We've all have to go through it or will go through it as females. And you have people that have been on that journey. So you're not alone and there is help and assistance available to you.
And to Dr. Moss's point, I actually started a community called Fibroid Layer Community, where it's filled with women that are talking about topics like this, whether it be menopause, endometriosis, fibroids, things. I just moderate like I'm doing right now and have live discussions, which every other week. So it's a community where women, it's a safe space where women can talk about it. If you're going to have surgery, you can talk to women that have already had surgery. So if you're interested in that, you can look at the link in my bio on my social media platforms, which is in the chat, as well as fibroidslayer.com. And I want to also address several women had messaged me privately about, mentorship. And I want to end on this note. And this is a little bit off topic as us as people of color that are here and professionals. We know that we are marginalized. There's a disparity in every profession, not just medicine, but law, engineering, you name it. As Black people, we are marginalized across the board, and our kids do not see us in these spaces of excellence, and therefore the 4 to 5% in all of these professions perpetuates decade after decade after decade. It's more Blacks getting accepted into medical school in the 70s than are in the 2020s, which is absolutely absurd. And to that point, if you guys have seen me before, the little book with the 3 doctors on there, I'm the one in the middle. Pulse of Perseverance is an organization that is based on mentorship. And what we've done is we've created a mentorship app because we have to meet these kids where they're at, to where now they can go into an app and not only follow and find mentors, but have mentors that they can see and they can scroll just like IG and any other platform to see these spaces, these people that look like them in spaces of excellence. So we need more mentors. So I urge everyone that's in the sound of my voice to go to your Apple or Google App Store and download the Pulse of Perseverance Mentorship app. We are growing rapidly, but we need as many Black people of excellence. I'm very intentional about that. And it's not cutting off any other mentors or what have you, because we have people of other races, but we need kids to see us in these spaces. And it's not just in medicine, it's across the board. So you have skills in wherever field that you're in, to reach out and help with kids. But as you download the application, you'll see how interactive it is. And it really, it cuts the element that mentorship is problematic the most, which is time. We don't have time to go in a classroom. We don't have time to do this, but you do have time to do a 60-second video so that 1,000 kids can watch it and see what you do for a living and see what it took. So please download the app. If anybody is in the Chicagoland area on May 31st, please come to support our fundraising gala, the Pulse of Perseverance fundraising gala. It's an awesome time, and we are raising funds to help continue this work. This app is free right now, for kids. We've partnered with multiple universities, and we will continue to grow with the support and help of our community. So if you cannot come, which we would love for you to come, but please look at our website, pulsap3.org, and donate and just help us as much as you possibly can. And as far as all of the fibroid discussions or what have you, please reach out to me. That's my lane. That's what I do. So if you have those questions, I do live discussions as well through social media platforms, as well as the fibroid slayer community. So I'm more than happy to talk about uterine fibroid embolization, pelvic pain with fibroids, and how to preserve your uterus and have options for becoming a mom, because we're not getting those options as Black women. And it's no mistake that 2/3 of all hysterectomies are still performed in southern states, right? It's been weaponized for Black women. So knowing your options, knowing that there are people that will advocate for you is extremely important. So I will end on that note because I know I get to talking too much. So, but thank you guys for having me as the only man here. I appreciate it.
Well, we thank you for being here. I was like, do you want 5 minutes to dive into that topic? I don't know if anybody is in a
I
rush to get
can.
off, but I know that there were several questions in there, and there were a couple other questions under Q&A. Yeah, talking about for those who've had a hysterectomy but kept ovaries, how will you know your menopause phases? We've answered, I think, a lot of the questions about non-hormonal options for people who are unable to take HRT. But there were lots of questions about fibroids, and I know that it is a big topic in our community. So, with you being our male, if you have to sign off, anyone, please, go ahead and sign off. But I want to give Dr. Pierre his time to talk about this topic because it is directly linked to all these other topics around menopause too.
Yeah, so I mean, knowing your options as far as fibroids are concerned, just in a global sense, I do the most fibroid surgeries of anybody like in the country, in the world. That's what I deal with, and the question that I get all the time is like, why does it impact Black women so much? Why? Um, and my answer to that is it impacts everyone, but specifically for Black women, it it has a tendency to impact at a more severe stage or just a more advanced disease. My definition of advanced fibroid disease, but dealing with fibroids all the time, is the dominant fibroid greater than 10 centimeters, or the combination of your fibroids expands to your belly button and beyond. And I see more Black women for sure that are impacted with advanced fibroid disease more than anyone. And that has to do with a multitude of different things, from the stress of being a Black woman to the burden of now being some of the first generation, debt bearers for your families, and now actually putting careers first and trying to be the first generation to create generational wealth, and putting families on hold or what have you, not to mention the access to quality healthcare and those types of things, and the insensitivity to positions of advanced fibroids. So all of those things have put women, like, now putting families later, and now in their late 30s, early 40s, now trying to look for families, and having all of this stress and other things advance the size of these fibroids, how that comes about. And so one particular question about UFEs, or uterine fibroid embolizations, and why people are like, well, why don't you like it, and why is it a big deal to you? And I will answer that and say that, number one, the conversation is not had a lot, is that we don't listen as providers, right? So if a woman comes in to me and says, hey, have fibroids, give me a minimally invasive option to that. And then their second sentence is, well, my question will be, well, what's your goal? And if you say, well, I want to have children, automatically that's a bad option because UFE is going to decrease your fertility rates, right? That means I didn't listen to you. All I saw was fibroids. All I saw was a dollar sign. All I saw was something to just treat you to shut you up. And I didn't hear that your number one goal is to be a mom. And if that's the case, UFE is not your first and primary option. And to that point as well, when I look at things that I tell my patients, I look at what works, right? What will I tell my mama? What would I tell my sister, right? So when I'm telling you that, and so the overwhelming majority of women that I encounter that have had UFEs do not have a lot of success. They're in pain, they have issues. There are some successes. I'm not saying that everyone that gets it is having a horrible experience, but there are way too many women that I operate on after UFEs or that are having multitude of symptoms like pain, continued bleeding with them, that it just doesn't work well. So I don't recommend it, and especially if you are looking to be a mom or utilize your uterus for childbearing, that it's not a very good option, to be honest. The other question, it was another question about, I wrote it down.
Well, Dr. Pierre, can I just add one thing to that?
Sure.
I also do energy assessments on patients using a different technology that uses quantum physics. And I know many people have heard about chakras, or the major chakras in the center of the body. And the sacral chakra, it literally is over the reproductive organs. And you said, well, why is it more predominantly worse in African American? We have more major issues with fibroids. One of the things that I've done is I always, in talking and communicating with my patients, I ask them sometimes about past emotional shocks and traumas, which can show up energetically on these scans. But also, if there has been previous history of molestation, rape, or even sexuality concerns or issues. You also mentioned people putting off their desire for children so that they can pursue careers. And so there's an internal conflict there. So that negative energy, or that lack of resolution of energy, or something negative about sexuality or in that area, can be a block of energy. We talk about acupuncture and chi and the flow of energy when you look at the Eastern medicine. And so commonly I see that. Now, I'm not saying everybody with fibroids has all these issues, but commonly, if, as a Black female, when I was growing up in church, they said, don't have sex, it's bad, you're bad girl, So all these natural feelings and emotions that you have regarding sexuality are then kind of have to be suppressed and shut down. And if anything negative also happened, then there's that internal conflict with regards to that. And so I believe a lot of women may have some nidus of energetic blockage as a result of that, not to mention, the exposure to the different xenoestrogens and all those things that cause those hormonal balances that will cause those tumors to grow as well. But I also wanted to just put that out there about how our emotional health, or that soulish realm health, can also impact our physical health. And so something for people to think about is they're going through their healing journeys, or even you, since you do so many fibroid slaying, it's something that you can actually look at as far as research or questioning as far as further evaluations. Because when you think about healing, not only do you have to heal from that surgery, but you also need to think about the healing that needs to be taking place with regards to why they got them in the first place, if that is an issue.
I'll finish up on a couple of points that are very, very hot topics for me on a day-to-day basis. Number one, there's never a need for vertical incisions for gynecology, and I say that proudly. That I don't care how big your fibroids are, or what it is. There's a way of not performing a vertical incision to perform surgery. And I've been doing surgeries for 13 years now, and I've not performed a vertical incision for hysterectomy, myomectomies in my entire career, and that goes for 20 pounds. So if we can deliver a 10-pound baby through a phalansteal incision like this, you can deliver a 10-pound fibroid the same exact way. The other thing is, hysterectomies have been weaponized for Black women. This is a true statement, right? So, whenever I talk about it, I'm very empathetic about that, and I'm very conscious about the history of our country and what that has meant for women. You've had aunts, you've had grandmas, moms, and everything that have had to suffer through brutal surgeries and had to recover from them. And therefore, there's a stigma around hysterectomies, which is rightfully so. But to that end, I will say that it is not a bad thing, though, when it's done appropriate. It is not to the point where it's not the right option for certain women. Just because it's been used in a very negative way for women does not make it to the point where it is a bad thing. And so when you look for providers, you need to look for providers that are going to give you all options and are going to honestly tell you about the things that make sense for your particular life, and do it in a way that no matter what will create less pain for you, less time for recovery, and look out for you as a person and not convenient for them as a surgeon. So you have to really, really search your providers. Do not allow your region or your community, the lack of access to doctors be restrictive to you. You know, a majority, I mean, I would say about 80% of my patients are not in Chicago. They fly in from either all in other cities in the country or even outside of the country to come in for surgeries, and they do their research. Know what they don't, they've heard multitudes of times that they have to have a vertical incision, or they've heard multitudes of times that they had to have a hysterectomy, no other option, and they take their time and do their research. I urge every woman, whether you need surgery or someone else in your family needs it, to do your research and know that you can use an insurance to your advantage. If you have an HMO and it's not covered, it's absolutely nothing to wait for open enrollment. Get a PPO plan, get that PPO plan for a year, and go get the surgery and things that you want. And that's not just limited to gynecology. That's with any procedure or anything that you need. So don't let your region or your community dictate the level or access of care that you need. And the last thing that I will say, and then I will be quiet, is that understand, right? That when you are, if you are looking to be a mom, or then that is your dream, it takes a plan, right? Everything in this life we plan. We plan our jobs, our careers, we plan the cars we drive, our houses, we plan every single thing. But then as it comes time to becoming a mom, it is, well, if God makes it happen, or if God lets me find this man, or if this happens, or what have you, there's something that the equation of pregnancy is very simple, to be honest, right? There's four components. There's sperm, that's free, right? We can have babies to the day we die, right? If I die right now, somebody put me, you can take me, roll me down, get sperm out of me, and have babies for the next 20, 30 years, right? So sperm is free. The house or your uterus, that can be fixed, right? That's just an aspect of it. No matter how bad your uterus is, it typically can be fixed to be able to house a pregnancy. The third aspect is the pathway. So the pathway from the sperm to meet the egg to actually fertilize it and then come back and implant into the cavity. That's not promised for everyone. You can have a perfect uterus. You can be in a monogamous married relationship and have everything all set up, and you have blocked tubes and have no way to get there, right? So the pathway, it is important for normal pregnancy, having sex for free and getting pregnant, but it does not mean that you cannot necessarily get pregnant. The final thing are your eggs. That is the most important part as it pertains to pregnancy, because from the time you start having your menstrual cycles to right now, as you talk to me, this is happening. It is going to continue happening. It's not going to wait for job, career, got to find this man at church, got to wait for this happen, got to get fibroid surgery. And then once it starts to do this, there comes a time where you will lose your ability to do what you want to do. There will come a time when you want to do that, and you don't want for that time to come when you're ready to get pregnant and you don't have the egg quality to do so. So as it comes to planning out your pregnancy, the very first thing you want to do is to preserve your eggs. It's almost like being at a casino, and I equate it to having like car insurance. We pay Geico, Progressive, State Farm, we pay them every single day. We will not touch a car, right? You will not touch your vehicle without paying them people their money, because if somebody sideswipes you, run into the back of you, you want to call them and say, hey, fix my car. I don't care how much it costs. As a matter of fact, give me a rental car while you edit. That's what we do. We pay for that insurance for and that peace of mind to be able to do that. So if you get to the point where your AMH or your egg quality is 0.1, 0.2, 0.3, it's, hey, those eggs that I had and that were preserved 5 years ago that have great quality, thaw those out, make me some embryos so I can use them to be a mom. It's not said enough. It is extremely important. So if you have the thought process of being a mom, the earlier you get those eggs, it's like being at a casino. You got sticks, you got chips stacked up, go cash them out. Because if you stay at the table long enough, at a certain point, the house is going to win. You're going to lose them, right? So it's not very expensive to at least keep them there. It keeps your option open, but it is the most important part. If you are in your late 30s, early 40s, you got advanced fibroid disease, or you got issues with infertility or what have you, it's not the uterus that's preventing it. It will be the eggs. You definitely want to preserve those as it pertains to your desire and your goals of being a mom. And let me shut up now because I will continue to talk. But thank you for giving me time to have this conversation. And
Well,
anybody
thank
else got
you
last
for
thoughts?
look. Thank you for sharing that, and thank you for going into detail about that. And I know it's a little off the menopause conversation, the perimenopause, and our menopausing, but it is a part of this whole women's health cycle. And I'm glad that you shared that. I know we went over time here, everyone, and I appreciate y'all that have hung in to the end. I saw a lot of questions about will we make the recording available? We will absolutely do that. We have on the line, like I said, Marcia Pico, who is the Director of Alumni Relations, and we also have Kimberly Reese, who is the Associate Vice President of Institutional Advancement. If either of you ladies want to come on and give us closing remarks. Our next thought leadership series is going to be in June, and it's going to be on Black men's health on June 17th. So please tune in to that as well, and have the brothers tune in, because that is you know, we have everything we need within our Xavier community and our network. Let's tap into each other, and let's build together, and let's take care of each other. Kim and Marcia, I'm gonna toss to you.
Thanks, Demetria. And I just want to say this. So this is Kim Reese. I just want to say to our panelists, our moderator, thank you for the information that was presented today. I tell people all the time, my favorite health expert who I see regularly, I need to get back on track with Dr. Larissa Ferdinand. So is on. So I want to personally thank her, and then all of our other doctors, definitely, and say to the ladies on the call that the investment is important in your life, right? So these experts that we have on the line, if you all are available, if you're doing telehealth, if you're doing consultation, let us know in the chat so that our ladies can sign up with you and get those going, because what we do know is representation matters, and healthcare is best when it's from people that look like us, who know us, who have our best interest in mind. And Demetria really summed it up in that everything that we need is in our Xavier community, everything that we need. And so I really truly want to thank our panelists today. And I hope that this is not the last one, and we can figure out how we keep this very important topic discussion going for many of us, and many of us is me that struggle with this every day. So I want to really thank you all, and thank you for being an engaged and active and caring alumna and alumnus. So thank you. Thank you so much.
Marcia.
No.
I'm dropping those websites in the chat so you all can grab them. And they also do, telehealth is fantastic.
Yeah, no, I won't hold everybody long. Everybody summed everything up. Thank everybody for being here. Thank you for choosing knowledge. Thank you for choosing community. And thank you for purposefully contributing to empowerment of everybody on the call and our Xavier community and beyond. Thank you, thank you, thank you. Just a couple of reminders about the alumni office. If you don't remember our email addresses individually, you can always contact someone at alumni@xula.edu. We do have our leadership conference coming up for Centennial, June 19th through the 22nd. It's the only leadership conference that we will have for the next 2 years, and it's going to be on the campus of Xavier in New Orleans. So please go to our landing page, which you can find at xula.edu/alumni. If you're available during that time, come collaborate, get some learning done with professionals and Xavierites in the New Orleans area. We'd love for you to be there. And homecoming is November 5th through the 9th in New Orleans. Do not forget about that. And again, to all the professionals on the call, if we can promote, help you in any way, yes, we have lots of things, all of the things, but the most important thing is making that time. If you've reached out to us and we haven't gotten to you in the past couple months, Centennial Gala is over. We're moving on through this summer. So please contact us and let us know how we can be of support. And we look forward to the next session.
All right. Thank you, everyone. And you have a fantastic evening and have a great Memorial Day weekend. Bye-bye.